I'm back with the Level Up RN Health Assessment cards. These actually have been beneficial to me. The last time I went live, I was actually going through the physical assessment steps. So I wanted to kind of pick up where I left off and also talk about respiratory assessments as well as pain assessments today. I did have some people who were interested in getting more information about that. We talked about the physical assessment steps, which was to introduce yourself when you walk in, as far as, you know, who you are and what your role is. So I would say, hello, my name is Ebony, and I will be your nurse for the day, night, whatever. And I am here to perform a physical assessment on you. Is that okay with you? And for me personally, I like to just get that confirmation and that consent. So of course you introduce yourself and then you perform your hand hygiene. You're either going to wash your hands while you're in there, or you are going to get some hand sanitizer on the way in, and be sure to get in between your fingers. And then the general survey, we talked about the general survey, which is when you're just kind of inspecting and looking at the person, nothing too crazy. Then the vital signs. I will actually go through vital signs in depth in another video. So today, like I said, I will be going through pain assessment. And then after pain assessment, there's skin assessment. Then your head, neck, eyes, ears, nose, mouth, throat assessment, as well as your anterior and posterior chest assessment. Your abdominal assessment. We did talk a little bit about the abdominal assessment last time. But there was a difference with the abdominal assessment. After you inspect, you don't want to palpate because you don't want things to start moving around in there before you auscultate, which is to listen. Also, musculoskeletal assessment, neurologic assessment, and closing remarks and safety checks, while also asking your patient if they have any questions or concerns or anything that you can do for them before exiting their room. So that's kind of the gist of how the physical assessment goes. So I wanted to talk to you guys about the different levels of consciousness. Levels of consciousness, this is where you talk about if the person is oriented, you know, 1 time, 2 times, 3 times, 4 times. They know who they are, where they are, time, place, event, things of that nature when it comes to levels of consciousness. So the orientation is what gives you insight about the patient's cognitive functioning. A normal finding is for the patient to be oriented times 4. That means they know who they are. They're able to tell you their name, the place. They know where they are. They know if they're in the hospital or if they're in a medical facility or where they are. They know the place as well as the time and the situation. The situation could be, you know, who's the president or what brought you to the hospital today. Just, you know, this is to help you to understand if they're cognizant in that moment or at that time. For time, the patient can identify the day, the month, the year, or even the season. Those are things that will let you know that their level of consciousness is on point at that time. Also, the Glasgow Coma Scale. So for anybody who is a nursing student, planning on doing nursing, or even just interested in medical school or anything in general, the Glasgow Coma Scale is very important because it's usually the scale that's used to assess the extent of a patient's consciousness based on a few categories. So the 3 subcategories that it's based on would be used for patients who have sustained head trauma. About the coma scale, so they're all rated based off of a person's head trauma. So they would get 4 points for opening their eyes spontaneously. Like if you were to enter the room and the patient opened their eyes, that would be 4 points to let you know they didn't need help opening their eyes. It would be 3 points if you had to actually like call their name and they opened their eyes in response to your voice. Then it would be 2 points in response to pain. 1, no eye opening at all, right? So then there's also the subcategory of verbal responses, whether they are coherent and oriented or incoherent, disoriented. If they're making inappropriate sounds, or if the sounds, it's just sounds with no words. Those are things that would be on the coma scale to let you know their level of consciousness. And their level of consciousness is based on a max of 15. So 15 points is max. That's the normal score, but a minimum score of 3. So anything between 13 to 15 means that they have mild head injury. And then 9 to 12 is moderate head injury. Anything less than 8 means severe head injury. The patient cannot protect their airway. So they definitely need help. If they have anything less than 8, that means they need to be intubated. Okay? I hope you guys understand that. If the patient is not oriented enough to be able to have any type of motor response, they can't follow commands, they are not coherent, they're not opening their eyes spontaneously, 9 times out of 10 they're going to have a low Glasgow coma scale score, and that means that they need to be intubated. They need you to help them. So again, I am going through the health assessment, HA health assessment, level up RN cards. These are really good for nursing students to help them to be able to retain the information for doing physical assessments and master the flow and sequence of how a patient physical assessment goes. That's what this is all about. And then we'll talk about the details of expected and abnormal results. Then I wanted to talk about was respirations. So this card discusses the assessment components as well as the assessment technique. Assessment components would be the rate, the depth, the rhythm, and the effort. So the technique is to put your fingers, so like let's just say after you've taken your patient's pulse, you're gonna leave your hand there. After taking their pulse, leave your fingers in place and observe the rise and fall of the patient's chest. Don't mention to them that you're counting their respirations, because a lot of times that can make a person nervous or even more anxious, and now they're breathing on a different level and you're like, just breathe normal, just breathe normal. So once you're already taking their pulse, you just look at their chest, see if it's rising and falling in a normal manner, or is it abnormal? Is something going on that you need to take a closer look at? So for a regular person, you want to count for 30 seconds. For a regular pattern, you want to count for 30 seconds and then you multiply that by 2. That's how you will get their respiration count. And then for an irregular pattern, you count for a full minute. You want to count for a full minute just to make sure that, you're kind of like, okay, maybe the 30 seconds wasn't enough because I didn't get the right count. Okay? Sticking with respirations, the expected respiratory rate for range in adults. As you go through nursing school, you'll mostly learn about things for adults, I guess, until you get to pediatric. But for adults, the normal range of respirations is 12 to 20 breaths a minute. Okay? 12 to 20 breaths a minute. That's what you need to know. For children, it's 20 to 30 breaths a minute. We know that kids breathe just a little bit faster than adults. But for infants, their breaths per minute is even higher. It's 30 to 60 breaths per minute because their lungs are smaller. So they can't expand them as much as an adult can, right? So you want to keep that in mind. But the magic number for adults, 12 to 20 breaths per minute. Anything in that range is normal. Again, don't let them know that you're counting their respirations, because you don't want them to do something weird and start breathing abnormally. When we're thinking about the depth of aspirations, you don't want it to be excessively deep or shallow. You want them to be breathing in a consistent manner. You just want it to be consistent. That's how you're gonna get the correct breaths per minute. And then the rhythm. The breaths should occur at regular intervals. Simply inhale, exhale, inhale, exhale. That's the rhythm of a regular breath. The effort that they're putting in to breathe, it should be easy and unlabored. There should be no if they're breathing like that, or they're hyperventilating or something, or maybe they're having an acute asthma attack, those are things that you have to be conscious and aware of, okay? That means that those respirations are abnormal. And we want to make sure we document those things. Always document, always document. So, the last thing I want to say about respirations are the unexpected findings. So there are things that we may not, think would happen to us with our patient at that time, but it can, and they may not look like they are having breathing problems, but tachypnea is what it's called when a person's respirations are more than 20 breaths a minute. So if they're breathing really fast, it's called tachypnea. Bradypnea, which is how I pronounce the word because it makes me think of breaks for slow, breaks, Brady. Those are breaths that are less than 12. So if you're having less than 12 breaths a minute, then that would be bradypnea. If your patient is hyperventilating, you're able to tell by the deep, rapid respirations. So that would be hyperventilating. Y'all have to excuse me. That's hyperventilating. HYPER. If they're hypoventilating, then it's going to be slow, shallow respirations. Okay. Irregular respirations, you would know. Anything that's not regular. Apnea. We should all know what apnea is, which is the absence of respirations for more than 15 seconds. So what should come to your mind? Sleep apnea. That means that your patient, your client stops breathing at some point, when they're asleep. So that's called sleep apnea. That's important for you to know. Dyspnea is difficulty breathing, and including the use of accessory muscles, nasal flaring, or retractions. This is usually seen in people who have acute asthma attacks. So you'll see the nostrils, they're trying to breathe. They're using all these muscles. You start to see the muscles here and in the chest, their nasal flaring and retractions. Those are used, and then even here in the lungs, you'll see the chest and everything is just kind of tightening up, and so that's how you know dyspnea. So moving on to oxygen saturation. Oxygen saturation, non-invasive technique that measures oxygen saturation of the arterial blood using pulse oximetry. So the expected oxygen saturation range is 95 to 100%. So for nursing considerations, Level Up RN tells us to place the probe on the finger, earlobe, or the toe. It's usually the toe for the babies, okay? Nail polish, hypotension. So nail polish, low blood pressure, peripheral vascular disease, edema, which is swelling, skin pigmentation, skin temperature. Those may affect the accuracy of your patient's oxygen levels, all right? So while a decreased oxygen saturation reading may indicate that the patient has low blood oxygen, hypoxemia can only be diagnosed with arterial blood gas test. So unless they have ABGs done, you really don't know if your patient is dealing with hypoxemia or not. We don't know how their blood oxygen is without getting the ABGs done. So oxygen saturation in the low 90s is expected for COPD patients. So if you know you have a patient who has COPD, you know they struggle with getting the carbon dioxide out, they're going to struggle with having the oxygen in. So their oxygen levels are usually a little lower, even though the ideal oxygen rate or range is 95 to 100. So don't be alarmed if you have a patient who's actually diagnosed with COPD and their oxygen says 92% or 91, something like that, 90%. They're still alive, but if they struggle with getting the carbon dioxide out of their system. But let's move on to pain assessment. For pain assessment, you want to remember it by the saying old carts. OLDCARTS. That's what's going to help you to be able to remember pain assessment. So old carts: onset, location, duration, characteristics, aggravating factors, radiation, treatment, and severity. When it comes to assessing pain, you want to know the onset. You know, when did this pain? Also, you want to know the location of the pain. You want to be sure to ask your patient or your client, where does it hurt? Is it constant? Does it come and go? You know, that's the duration. How often are you getting this pain in that location? The characteristics. What does the pain feel like? So under characteristics, there are two types of pain that your patient can describe. It can be nociceptive pain, which is describing it as aching or throbbing, but it can also be neuropathic pain, and that would be the shooting or burning pain that some people feel in their limbs. So aggravating and relieving factors: does anything make it worse? Does anything make it better? You know, do you use heat compresses? Do you use ice? Is there anything that we can do outside of medication to help you with that relief? And then there's radiation. Does the pain move anywhere else? Is it radiating through your body? That's what that means when we talk about the radiation of pain. And treatment, when it comes to treatment, have you tried anything to treat your pain? Like I was saying, ice, medication, heat. You know, what are you using for pain management? That's important for us to know as nurses. So for severity, you want them to rate the pain using the appropriate pain scale. For me, it's the pain scale of the Glasgow, 9 times out of 10, or the numeric pain scale. I think most of us who have been to any doctor or any doctor's pain scale, and it's the one with the little smiley faces that goes all the way to like the sad hurt face. Okay, so there are different pain scales for different age ranges. If your client is less than 6 months old, they have a pain scale of cries. It's called cries. So they're crying, requiring oxygen, increased vital signs, expression, and sleeplessness for the babies. Okay, and then any age range from 2 months to 7 years, that pain scale is called FLACC, FLACC. Face, legs, activity, cry, consolability. For the age ranges that are greater than 3 years old, we use the Wong-Baker faces. So you're able to use those diagrams of the 6 faces that I was just talking about to rate the pain from 0 to 10 on a scale. And then the a little bit older, that age range for pain is going to be the 3-year-olds to the 13-year-olds. There's a pain scale called Alcher, and the components of it is when you use 6 photographs to rate the pain on a scale of 0 to 10. So kind of just like the Wong-Baker faces, as well as for anybody that's over like 8 years old, they can just simply use a numeric pain scale. So, hey, can you tell me on a scale of 0 to 10 how much pain you're in, with 10 being the worst absolute pain of your life, 0 being no pain at all? I'm doing very well. Like, that's, you know, the gist of figuring out the pain scale. If you guys have any questions, please feel free to ask them. If you don't want to ask them in the comments, I do always respond to all messages that I receive in my DM. I wanted to come and show you guys the extent of what health assessment is. I had people to ask, like, what is health assessment? It seems so simple, but at the same time, there's so many moving parts to health assessment. And I do plan on doing some videos on the skills so that you guys can actually see and understand that. I did go through the health assessment, level up RN, respiratory assessment, and pain assessment, as well as the pain scale. Thank you for watching.